All right, well, we are right at 2 p.m. My name is Michael Corey. Thank you, everybody, for joining us today for our webinar. Today, you're going to hear from Dr. Catherine Tomko with the Bloomberg School of Public Health. But first, we are going to hear from the Opioid Operational Command Center's Executive Director, Robin Ricard. And just before we get started, again, everybody, if you could please just keep your microphones muted throughout the duration of the presentation, we'd greatly appreciate it. There is a chat box if you have questions throughout, and there will be Q&A at the end of the session. And then just lastly, in case you missed it earlier, the session is being recorded for your awareness. But without any further ado, I will hand it off to Executive Director Ricard.
Good afternoon, everyone. Again, my name is Robin Ricard, and I'm the Executive Director of the Opioid Operational Command Center, or we call ourselves the OOCC. Thank you, everyone, for joining us for today's webinar, Overdose Fatalities in Maryland Jurisdictions and Implementation of Overdose Prevention Strategies. Today, you're going to hear from Dr. Catherine Tomko, who is a postdoctorate fellow with the Johns Hopkins Bloomberg School of Public Health. Dr. Tomko will describe the work that she and her team have undertaken to assess the programs identified in the OOCC Substance Use Disorder Program Inventory. One of our primary missions at the OOCC is to assess all efforts being undertaken at the local level to address the opioid crisis. When establishing the OOCC in 2017, Governor Hogan tasked our office with helping to increase collaboration between state and local partners to help share best practices and to identify and fill potential gaps in resources. To do this, we coordinate routinely with our partners in all the 24 jurisdictions in the opioid intervention teams, or OITs, to learn about the efforts that you all are undertaking, so that we can learn about what is working best at the local level to help people living with substance use disorders. And I know many of you on this webinar today are OIT members, but just in case you're not familiar, OITs are multi-agency coordinating bodies that seek to enhance multidisciplinary collaboration at the local level. To aid this process, we created our OIT program inventory to track the implementation of various programs across the state. The inventory tracks 143 programs that are being implemented at the local level in a wide variety of settings, such as hospitals, schools, universities, the criminal justice system, and the behavioral health system. Over the past year, the OOCC began engaging with the Bloomberg School to take a closer look at the program inventory. And the project will consist of a few stages. First, the Johns Hopkins team assessed the progress that local jurisdictions have made in implementing high priority programs in recent years, which we'll hear about in just a few moments. And then moving forward, we'll look at ways in which we can standardize data collection and assess the impact that these programs are actually having on local overdose rates. We're very excited about the partnership because the work being done at the local level is vitally important for our collective efforts to reduce overdose deaths across Maryland. Each jurisdiction, each local community has its own unique needs, and you are all best equipped to address those needs. And the more that we can support the work that you all are doing to share lessons learned and best practices from program implementation at the local level, the more we can do to elevate our collective response efforts and help improve the lives of people with substance use disorder. So I will hand it over to Dr. Tomko so that you can hear more about this important project. And thank you, everyone, for joining us today. And thank you for all that you do. Remember, tomorrow is Overdose Awareness Day. Wear your purple. And I'm sure we'll see a lot of you out in the community tomorrow and the next day, and also in September for National Recovery Month. Thank you so much. Dr. Tomko?
Hi, everyone. Thank you. Thank you so much, Robin, and thank you all for joining today's webinar. I'm very excited to present on this topic. As Robin and others have said, my name is Catherine Tomko, and I'm a postdoctoral fellow at Johns Hopkins School of Public Health. And so on behalf of the Maryland Overdose Data Collaborative at Hopkins, I'm going to be presenting on overdose fatalities in Maryland jurisdictions and implementation of overdose strategies. Next slide, please. And before I begin, I just want to acknowledge first that this work is funded by the CDC as part of the Overdose Data to Action Initiative. And I also want to thank the support and assistance we've received from folks at the OOCC, Robin, Marianne Gibson, Teresa Heath, Michael Corey. You've all been so wonderful in helping us with this research and evaluation, I should say, and helping to organize today's webinar. And also, we want to thank Dr. Monique Wilson and Janetta Churchill at the Vital Statistics Administration for providing us with mortality data. And I will say that this is, there's a standard, standard language that we do want to say that this is funded by the CDC, that the contents here are not representative of any views of the official views of the CDC. Next slide, please. So just as some background, OD2A is an evaluation is concerned with 9 strategic areas broken up into surveillance and prevention components. And they're related to overdose prevention and surveillance. And you can see each of the strategies here. So these goals are common across all OD2A projects, not just the one in Maryland. And they ultimately aim to monitor and improve outcomes and quality through the strategies that you see here. And in particular, the evaluation that I'll talk about today falls under strategy 5, which is integration of state and local prevention and response efforts. Next slide, please. And this is just the MODC team at Johns Hopkins, and it's led by Doctors Renee Johnson and Ju Park. Next slide, please. So this is just a brief outline of today's presentation and what I'll cover. So first, I just want to walk you through the evaluation of OOCC program implementation and overdose mortality. And then we'll briefly highlight the importance of reporting that OITs do in the quarterly surveys for the OOCC. We'll discuss next steps for evaluation. And finally, at the end, there's a Q&A period. Next slide, please. And next slide. Thank you. So now that we've heard some background on who we are and what our purpose is here as an evaluation team, I'm going to talk about our work with the OOCC specifically. So this slide shows opioid overdose deaths in Maryland between 2016 and 2020. So mortality has been hovering around 2,000 to 2,100 individuals each year until 2020, when deaths hit their highest point in recent years with almost 2,500 overdose deaths. So the high mortality burden across the state shows a clear need for opioid overdose prevention and response, which the OOCC is tasked with coordinating. Next slide, please. And as you all probably know very well, at least most of you, every quarter the OOCC surveys OITs in each jurisdiction across the state about implementation of overdose prevention and response programs and strategies within that jurisdiction. So the program inventory asks about 145 programs total, and these are all the programs that are monitored by the OOCC and may be implemented within a jurisdiction. So the programs are classified according to 12 domains that represent different public sectors. And you can see all 12 domains on this slide. So within each box, you can see the name of the domain, the total number of programs within each domain that the OOCC tracks, and then some example programs that fall within the domain. Next slide, please. So in this evaluation, you can actually go back for 1 second. So in this evaluation, just to kind of set this up, we used data captured by the program inventory and the OIT's responses to the survey to investigate the state of implementation of programs across the inventory. And so what we did was we linked opioid overdose mortality data from Vital Statistics Administration to the survey data that you all provide to better identify jurisdictions with high per capita opioid overdose mortality, but limited implementation. And so we're hoping that our findings can be used to identify counties with high overdose mortality, low program implementation, and so that they could be provided with additional supports, whatever those may be for that jurisdiction. Next slide, please. So this was our evaluation question. And specifically, we were looking at whether counties with per capita opioid overdose mortality above the median in 2019 were more likely to have fully implemented a larger proportion of the 145 programs within the inventory. We were also looking at whether those same areas implemented a larger proportion of programs within each of the 12 programmatic domains in the inventory. And then the last thing you'll see is that there are 10 programs specifically designed to increase access to naloxone. And these are across domains. And so we specifically looked at the implementation of those programs and how those were associated with mortality. Next slide, please. So the count of fatal opioid overdoses in 2019 by Maryland County came from the Department of Health's Vital Statistics Administration. So we standardized per capita opioid overdose mortality per 100,000 individuals. And we did this by dividing the opioid overdose count by the county population, and we used 2019 census data for that, and then multiplying that by 100,000. The opioid overdose rates were defined as unintentional intoxication deaths. So that means fatal overdoses that excluded suicides, resulting from the recent ingestion or exposure to opioids. And this is all derived from death certificates. Like I said before, the individual county populations were derived from the 2019 census data. And so this data reflects deaths occurring within the county, regardless of if that individual was a resident of that county or even a resident of Maryland. And so part of the reason that we decided to do it that way was because we felt that understanding, regardless of residency, the burden of overdose happening within that jurisdiction was more important at this point than residency. So that's why we chose to do it that way. And I will also say that an important note to remember is that unlike some other data you might see from the VSA about mortality, specifically overdose mortality, these numbers only represent 1 year's worth of data. So calculating per capita mortality for jurisdictions with really small populations can result in very different year-to-year estimates because the denominator is small. We also only wanted, for this purpose of this valuation, to look at 2019 data. So that's part of the reason we only chose 2019. But so you know, if you're looking at other estimates from the VSA, sometimes they have estimates that take a 5-year average. For this, we're only using 2019 data. And so areas with small populations may have year-to-year differences in mortality. Next slide, please. So like I said earlier, we use the OOCC administrative data set for this evaluation. And we use data from surveys completed by OITs in the first quarter of 2021. So the following codes were response categories on the survey that OITs complete for each of the 145 programs. And these represent the level of implementation of that specific program. So for example, 4 would equal substantial implementation is already in place. 3 means some programming is in place or partial programming. 2 means that programming is in development or planned. And then 1 is no programming planned at all. So for the purpose of this evaluation, we recoded these responses to compare substantial implementation compared to any other level of implementation. So the results that we show are just for full implementation at the highest level that an OIT can record. And These data, again, are from the first quarter of 2021. So they represent the results of the implementation work that took place in 2020 and by early 2021, after counties already had information about their 2019 overdose mortality. Next slide, please. So we first calculated the percentage of substantially implemented programs across all 145 programs. And the percentage of substantially implemented programs within each domain. For each county, we summarize the level of implementation of naloxone programs in the same manner. So we looked at whether it was a naloxone program was substantially implemented or not. And we then conducted correlations to test the statistical significance of the association between mortality and substantial program implementation. So correlations can't tell us if 2019 mortality caused subsequent implementation by 2021, but it can tell us the relationship between the variables. So we would expect that jurisdictions with higher mortality in 2019 would have higher implementation by 2021 to meet the mortality needs of that jurisdiction. So this would be a positive correlation between the two. We used 3 different types of correlations based on the distribution of the data. And if you're interested in the specific tests we use, I can talk about those in greater detail at the end of the presentation. Next slide, please. And next slide. So this is a summary of per capita opioid overdose mortality across the state in 2019. In total, there were 2,106 deaths, and the median mortality, which means half of jurisdictions were above this and half were below, was 30 deaths per 100,000 individuals. Baltimore City had the highest per capita mortality with 139 individuals per 100,000, and Montgomery County had the lowest with 8. Next slide, please. So this graph shows the percentage of all 145 programs in the OOCC program inventory that were substantially implemented in Q1 of 2021. So the blue bars show the percentage of substantial implementation by jurisdiction. You can see all of the counties listed or the jurisdictions listed at the bottom. So across 24 jurisdictions, the median percentage for substantial implementation was 51%. And Harford County had the highest percentage of substantially implemented programs with 79%, which is up here, and Calvert County had the lowest with 27%. Next slide, please. And so on this slide, you can see, first, I'll just point out that the broken blue line up here was 51%, which is the median percentage of substantially implemented programs across all jurisdictions. And now on the right-hand axis, we have per capita overdose deaths by jurisdiction. So remember that median mortality is 30 per 100,000 individuals, and that's represented by this broken orange line. So any county that appears with a blue bar underneath this broken blue line and an orange dot above the orange line are counties with high mortality but low implementation. We know that implementation and the issue of opioid overdose is incredibly difficult, and the slide is not to single out any one area or jurisdiction. This graph is just representing, and any other appearing in this presentation, are showing the current state of implementation, and part of the evaluation that we did is to find areas that may need additional supports from the OOCC. And next slide, please. So when we conducted a test of statistical significance, we didn't see any evidence to show an association between per capita opioid overdose mortality and all program implementation by 2021. So this means that counties with higher mortality in 2019 were no more likely to implement programs by 2021 than counties with lower implementation. Next slide, please. So the first column of this table shows each of the program domains that I talked about earlier and the number of programs within the domain. And the second column shows the range of substantial implementation percentage across all 24 jurisdictions. There was notable variation in implementation across domains and counties. So, for example, the social services domain had the highest median percentage of substantially implemented programs at 80%, but had one of the widest ranges of implementation, with some counties implementing all of the programs within that domain and some having not implemented any. Every county implemented at least one program in the behavioral health, education, OIT, and police domains. And the last column displays if there was a statistically significant association between mortality and implementation. So there was a positive and significant association between mortality and implementation for only one of the 12 domains, which is the public health domain. So that means that jurisdictions with higher mortality in 2019 tended to have greater substantial implementation by 2021 for programs within the public health domain. But for all other domains, jurisdictions with high mortality in 2019 were no more likely to have implemented programs within each of those domains than jurisdictions with low mortality. Next slide, please. Next slide. Thank you. So we also investigated implementation of programs that included naloxone distribution, education, and training because of naloxone's importance in preventing overdose mortality in the event of an overdose. So we used the same methods as other analyses we showed. The only difference is that these programs cut across domains. So you can see in the right-hand column which domain each of these programs came from. And unsurprisingly, 4 of the 10 came from the public health domain. Next slide, please. Across counties, the median number of naloxone programs with substantial implementation was 7. And again, that's shown by the broken blue line on the graph. Calvert County had the smallest number of programs with substantial implementation, whereas Washington and St. Mary's counties had the greatest with 9 of 10 programs. Next slide, please. And this slide shows the number of counties that have substantially implemented each type of naloxone program. So 5 of the naloxone programs had been substantially implemented in 20 or more of Maryland's 24 jurisdictions. So those were naloxone training, police trained in naloxone, naloxone distribution, naloxone available in schools, and police carrying naloxone. Substantial implementation was lowest for syringe service programs and mobile SUD support services. Next slide, please. And again, tests of statistical significance did not show an association between 2019 overdose mortality and substantial implementation of these naloxone programs by 2021. So again, in other words, this means that counties with higher overdose rates were no more likely to have implemented more programs than those with lower overdose mortality. Next slide. And next slide. So just to kind of give you the broad strokes conclusions of this evaluation. So in terms of substantial implementation of programs across domains, the highest percentage, again, were social services and OIT administration. They had the most or the greatest percentage of substantial implementation across jurisdictions. Higher education, judicial, and corrections domains, the programs within those domains had the lowest percentage of implementation. Next slide, please. So in general, higher opioid mortality in 2019 was not linked to increased implementation of programs by 2021. We didn't find a statistically significant association between mortality in 2019 and implementation of all 145 programs or the 10 naloxone programs by early 2021. However, we did observe a statistically significant association between overdose mortality and substantial implementation of programs within the public health domain, suggesting that public health agencies may have been able to respond to overdose rates by early 2021. Next slide, please. 7 counties had per capita overdose mortality above the median for the state, which again was 30 individuals, but below median implementation of overdose prevention programs. Given their high mortality, these counties we are recommending should be provided with additional support for overdose prevention program implementation to kind of meet the needs of implementation and mortality. Next slide, please. And this would not be possible if OITs, you all didn't provide, timely and accurate data, and we are very thankful for that. And we want to show what happens when you fill out one of these surveys every quarter, where the data is going and how it's being used. And so the OIT's timely and accurate reporting of implementation allows OOCC to monitor progress across the state of these programs and to determine areas that may need additional support for implementation. So we just want to, hammer home the idea of the importance of the reporting that you all do. Next slide, please. So just kind of looking forward to our next steps, there are several next steps that could be taken to strengthen our conclusions and expand on our findings. So the first is an outcome evaluation, so that given the implementation of overdose programs should lead to reductions in overdose mortality and morbidity. An important next step is to conduct outcome evaluation, where we can see whether implementation of some combination or suite of programs in the program inventory are associated with subsequent decreases in mortality and morbidity, or at least slow the rate of increase across jurisdictions. The second next step is to review the evidence base. So there is a need to review the evidence base for all the programs in the OOCC inventory so that distinctions can be made about the effectiveness of each. Right now, the assumption sort of with this evaluation is that all of the programs are kind of equal value or could equally contribute to preventing or responding to overdoses, and resources should be targeted toward programs with stronger evidence for preventing overdose. So programs that may increase that risk, even inadvertently, should be reconsidered. And so the strength of the evidence will be incorporated into an outcome evaluation in the future. The third is to ensure comprehensiveness of the program data. The OOCC program inventory is intended to be an exhaustive summary of the programs it includes, but some programs just may not be captured. There may be things that in one of the domains, higher education, if there's a private college that has some sort of substance use disorder screening, there may be programs that exist, for example, in a private institution that the OOCC just wouldn't be under their purview. So the data could be strengthened if implementation was compared to other sources of information, such as data from other MDH agencies, or just trying to understand the exhaustiveness of the landscape. And the final thing, and this is, I think, one of the most important, is to understand the social, cultural, and structural determinants of program implementation. So one limitation of this analysis, or something for you to have in the back of your mind, is this analysis doesn't account for socioeconomic, cultural, or normative differences across counties that may explain differences in program implementation or overdose rates. So some jurisdictions may have a long-standing naloxone program that's well integrated into the community, while other places may have a brand new program that was very controversial. So we can't capture those differences right now. That's something that we'd like to do in the future. Political opposition, trying to understand political will and political opposition to certain initiatives, such as syringe service programs, or just population characteristics of jurisdictions. We would like to develop a data set capturing some of these strong contextual determinants that could set a foundation for accounting for social factors in an outcome evaluation. All right, next slide. So that's that is are the results of our evaluation. If you have any other further questions, we're going to have a Q&A session now, but other further questions or comments, or you just want to reach out and discuss any of this, there's my information here. And then there's also information for Dr. Ju Park, Dr. Renee Johnson, who are the PIs of this project, and Taylor Parnham, who is the project coordinator. So thank you so much, and I'm excited to hear your questions.
And I'll just hop in here. If you did call in on your phone, you are able to unmute yourself by pressing *6.
Hi, I have a question.
Go ahead.
I'm just curious what impact you think pandemic response had on ability to expand implementation of some of these programs.
Yeah, I think that is probably the biggest factor that we couldn't necessarily account for, and that probably explains a lot of the null associations between mortality and implementation, because we know that resources and focus and person power all were completely rerouted because of the pandemic, and that will affect certain areas. You know, the crisis mode can affect certain areas longer than others. So that is probably the biggest thing, and that's why we're looking at other ways to look into the data to see how we can account for contextual factors like that, and then kind of trying to look at implementation as it is associated with mortality. So we can see, like, were people, which of these programs had the biggest impact when they were implemented. But yeah, I think that's probably the biggest limitation, I guess, or reality, really.
Thank you.
And we did get a question in the chat box. So Brandon Gosnell asked, did I hear correctly that you only looked at the first quarter of 2019 and not the entire year?
So we looked at all of 2019 mortality, but we looked at the first quarter of 2021 when it came to implementation. So our thinking was that basically 2020, it would give a year of time between sort of jurisdictions understanding where 2019 mortality was by the end of the year, and then the first time, the 1 year of lag where implementation could take place. And then the first quarter of 2021 would be kind of where things stood after that year-long period of potential implementation.
Looks like Elise Andrews has her hand up.
Thank you. I was wondering if you could go back to the slide where you had all the counties listed and you had, I think it was blue dots and orange dots. Could you just walk through the explanation of that again? I was writing stuff down and I just think I didn't catch all of it.
Sure, absolutely.
Thank you.
And if you give me just a moment, I will pull that up for you. 1 second, please. Okay, got it.
Thank you. Okay, so yeah, this is a busy one, but so on the left-hand axis, there's the percentage of programs of all 145 programs in the inventory. The blue bars represent the percentage of those 145 programs that were substantially implemented by the beginning of 2021. And then this broken blue line here just shows the median, which was 51% of implementation. So anything that's any jurisdiction that's above that broken blue line has above like what we termed high implementation. That just means above the median implementation. On the left or the right hand side, we have mortality from 2019. And so this line here just shows where mortality is for each jurisdiction. And this broken orange line is what the median is for mortality. So for this, kind of the way that I think that the most helpful or like the biggest takeaway to read this slide is any place, any jurisdiction that has a line that's lower than the median, but a blue line that's lower than the median, but an orange dot that's above the median, those are kind of the areas that we that have high mortality and low implementation. So those are sort of some of the areas that could probably, there's just like more work to be done and more strategic thinking about how to implement things.
Hey, Catherine. Just as an example, could you just call out like maybe 5 of the counties that you see as falling into that category of counties that may need additional support according to this analysis?
Sure. So, for example, Cecil County has so it's their percentage of substantial implementation is 44%. So that means it's lower than the state median at 51%. But it also has about like 50-ish individuals per 100,000 mortality, and that's above the median for mortality. So similarly for Somerset County, like Somerset County is another example. Anne Arundel's right on the border of both of them. But you can see down here, for example, that Garrett County is below the median for implementation, but they're also below the median for overdose mortality. So it's just, this is just kind of a way to include both of them on the same slide and kind of looking in this kind of middle area.
Any other questions for Dr. Tomko?
I was also wondering if Dr. Tomko, you might have questions for the audience.
Yeah, absolutely. So I think, as we are the evaluation team are thinking about the next steps and where can we go, one of the things that we are interested in is kind of hearing from you all about which programs or sort of the types of programs that are being offered. Is there anything that you all would be interested in hearing more about with respect to evaluation? Or, one of the things we'd like to do is review the evidence base of these programs. Like, are there programs that you are more interesting to you for us to do that? Like, we basically would like to get your feedback as a way to, really have our evaluation focused on what is most impactful.
Let's see, and I do see a question from Howard Burkham and then Earl Stoner.
Not sure if I'm unmuted.
We can hear you, sir.
Oh, okay. On one slide, it showed that with public health, there was a significant association between mortality and implementation and programs by public health only. And on another slide, it gave the programs that public health was responsible for, including naloxone distribution and naloxone training. Can you narrow that down to saying that distribution of naloxone by public health itself is a big factor, or do you think the other three are also contributing there, or did you break it down that way?
So we didn't break it down that way. So I will say, so in the public health domain, there's a total of 18 programs that are within that domain, and naloxone distribution and training to the lay audience or just the general public are a couple of those, but then there's also prescriber education, there's fentanyl test strips, there's wound care, like so we didn't look at each of the individual 18 programs and their association. We looked at them, just the percentage of those 18 programs that were substantially implemented. So we can't say that any one program was more effective than the other. But like I said, I mean, the public health domain could potentially be an area where we do kind of dig into that further and look at individual programs. Is there one in particular that you are most interested in?
Well, I saw naloxone distribution at the top, and we're talking about mortality, so it seemed like an obvious thing to ask.
Eric, do you have a question?
Sure. I'm sorry. I thought there was somebody ahead of me. Thank you very much. And thanks to the OOCC. I love the relationship that we have with all of our partners in the state. We were fortunate in Baltimore County to be able to do an internal study using our OD2A grant. So we used a vendor to do an internal study of our OIT. And one of the positives that we gained was getting feedback that we've done a good job of opening up silos among the different departments in Baltimore County. So in Baltimore County, we have all of the departments being present and involved in our processes. And I just hope that there's some way to make sure that on the state level, that's going on in the same way. So in other words, we're no longer funneling things through the health department, it's everyone. And so my fear is that if things get to the state level and it's filtered through the health department again, it creates a bottleneck where I think there needs to be more buy-in from all of the different departments for things like transportation, housing, things that we talk about in our OITs, that when you get to the state level, I think that we could do a better job of getting information to those different departments. And I know the OOCC does an incredible job with that. I mean, really, but it's more of a culture change, and I think it takes a long time. And I think that in order for it to work, there have to be people in those departments who are ready to have conversations about these things. And I'm just wondering if that's something that you could take a look at as you move further. Thank you.
I think that's an excellent idea. We know from, I know from work that I do in Baltimore City, but just in general, that things like transportation it's critical, and it's such a barrier for people. So I think that's excellent that you guys have been able to kind of work across those areas in Baltimore City or Baltimore County. And I think that that's certainly something that we can look into in the future, or at least try to help encourage that in other areas.
my team has certainly done all of the work. I give them all the credit. They've done a great job. Thank you.
And I just want to echo what's going on in the chat, but just to tell everyone that we do have county-specific slides related to this. So we have slides like the graphs, and the figures that I've shown here for kind of the entire state, more or less. We have individual slides for individual jurisdictions. So you can reach out to us, and we can send those to you, so you can kind of see more in-depth information about your particular jurisdiction.
And a question that we got that was similar to that. So Brandon Gosnell said, I would love to see the breakdown of program implementation per county and to see links to success, but also an analysis based on demographics would be helpful as well.
Yes, that is. We have put together a data set with that population characteristics and things like that by jurisdiction. And so that is our next step.
Any other questions? I don't see any more currently. One from Tiffany Scott. Would love to see the breakdown for Baltimore City and the implementation for young people between the ages of 16 and 30.
I think is Tiffany, is that who asked? Could you, if you're able to, could you add a little bit more information about specifically kind of what you're looking at with that population or what you're interested in?
If there's any demographics that could be provided for service delivery for that age group would be excellent. Thank you.
Sure. So right now we don't have any data specifically about like implementation within that population. I would say that we do have information about education and higher education, which are focused on those areas. And there are things that have, there's like high school and middle school age programming specifically. But that's a great point. I'll write that down and see if that's something we can look at. Thank you.
Okay, well, I don't see any other questions in the chat box at present. Now would be the time to get in any last questions before we end our session. So if anybody has any left, please do ask. Otherwise, I'll hand it back to Dr. Tomko to end our session.
All right, I'm not seeing any other questions right now. So I thank you all so much for attending and for your questions and feedback. And like I said, you can reach out to me at any time. We have county specific results that we can share with you all. And we really are, as we're moving forward, we want this to be collaborative, not just with the OOCC and leadership, but really from OITs, like you all are doing the work, putting these things into practice, and we want to know, what can be most helpful for you all. So if there are things that you think would be helpful for us to know, or ways to approach our evaluation in the future, please don't hesitate to reach out. And I would love to, talk to you all and kind of just hear what you have to say. So thank you. And I guess.
Well, thank you so much. And like I said, this session was recorded, and we will be making a copy of it available on our website in the coming days. Thank you, everybody.
Thank you.
Thank you.